Our next speaker is Dr. Stephen Mark, whose name's been mentioned several times already this morning. I've appreciated getting to know Stephen and his role as chair of the New Zealand section of the Urological Association Society of Australia and New Zealand. It was also Mark and my privilege to be hosted at the USAN's conference in Brisbane earlier this year, along with our colleagues from Australia as well. And we had a very profitable meeting with their executive, moving towards establishing a memorandum of understanding with that organisation. For us, that's a very key partner. The whole theme of this conference is about partners working together, and this is a very key partnership that we have with Stephen and his organisation. Stephen, thank you for coming up from Christchurch to speak to us. I look forward to what you've got to tell us. Thank you.
Kia ora and welcome from the home of the Crusaders, which still staunch rugby supporters. Originally I'm from Otago, so I'm actually a little bit gutted, but at the end of the day I think we'd all have to say we'd support a New Zealand team first. I'd like to congratulate Mark and Graham for moving this organisation into a really professional organisation, and I stand here today as a representative of the Urological Society of Australia and New Zealand. That's the body of urologists that incorporate both educational, training and standards, and have a similar understanding with the Prostate Cancer Foundation of Australia, and work well together to try and provide the same common goals, and that's a goal of advocacy, a goal of support and education, and a goal of working together to help men with prostate cancer and testicular cancer, which is a significant component of our workload. What I would like to do today, I've been asked to talk a little bit about advances in diagnosis and treatment of men with prostate cancer, so I thought I'd touch in a little bit of detail prostate cancer screening and where we are at with that. To look at how do we improve the diagnosis of prostate cancer, to look at some of the more recent surgical advances, because surgery is one of the things that I undertake, and also to look at how do we improve the overall outcomes of men with prostate cancer. Some of this will duplicate a little bit what John has talked about, but I'll try and minimise that and move things forward in those four areas. Just a little bit of background. I'm currently the clinical director in the Department of Urology, and most of my role is in fact in both paediatric and reconstructive urology, but a significant amount of work in prostate cancer, and I see a number of patients in the room here today that I've been involved in treating. Secondarily, it's really good to see a lot of men and women's faces in the audience, because this is not a disease of men in isolation, and I think it's important that we acknowledge the importance of support as part of this. And one of the important aspects of the Prostate Cancer Foundation of New Zealand is education and support, and they are taking a very professional role in this. I'm a member of the task force, as John has mentioned. USANS has been founded since 1937, and it has a really important role in Australia and New Zealand at maintaining standards and education. So if we move things forward a little bit, John outlined this a little fraction, but I'd like to go into a wee bit of detail. There is quite a dilemma with prostate cancer. We're all living longer nowadays. We all have higher expectations of our health and our health system. As we've heard, prostate cancer is very common. However, PSA as a test is not a diagnosis of cancer, it just raises a suspicion. Not all prostate cancer is fatal. In fact, 1 man in 8 is diagnosed, but 1 in 36, it causes a fatal illness. So there's quite a gap there where a number of men diagnosed may not necessarily die of that condition. So that's a conundrum from a management point of view. We know nowadays, as John has pointed out, with active surveillance, low-risk disease can be treated safely. And treatment is morbid in some circumstances, but it has improved a lot. Despite being reminded by my wife consistently that I'm ageing, the process of improvement is quite significant over the time that I have been a urology trainee and a consultant. The treatment of prostate cancer when I was in training, 16 to 17, probably longer than that now, years ago, was a long operation, a high chance of a blood transfusion, a high chance of urinary control difficulties, and most men presented significantly later, so the chance of cure was less. Nowadays, our public hospital stay is shorter than our private hospital stay. The average is 2 days for an open prostate operation. The blood transfusion rate is 3%, and the rate of transfusion is no different than if a surgical senior trainee is involved in the operation or a consultant. And we've looked at the outcome measures of our continence rates, which are between 80 and 90% at 1 year. And therefore, the treatment has improved significantly, and a lot of the information that we hear about isn't necessarily reflected in modern results. So, talking about how common is the problem. As we've heard, it's the commonest male cancer diagnosed. However, only 9% of patients end up having mortality from that. And as we can see, not all patients age similarly. Some patients have significantly poor health outcomes in their 40s and 50s. And all of the men in the running race are in the over 85 section, and their expectation of their health is quite different. So we can't necessarily lump all people together by age. Prostate cancer screening seems logical. Why not look for it earlier? Why not test for it? Why not diagnose it earlier? Why not treat patients? They should all get a better outcome. There are 4 criteria to be a screening test success. Firstly, there needs to be a common disease. That is true. Secondly, there needs to be a diagnostic test that's available and applicable. That is true. There needs to be effective treatment. That is true. However, there also needs to be studies that are undertaken in large populations over a period of time that show a benefit in outcome for that population that's studied. And screening is a, by definition, mandate of a population that's funded. So they'll say PSA testing is funded, and are all the consequences. Looking for a cancer based on someone having concern and having a PSA test done is not by definition screening. That's not what we're talking about. This is a policy that's handed down, mandated and funded. This has been studied and is currently being studied. And just to give you an idea of the size of those studies, in the European study that's being looked at the moment that has 11-year data follow-up, look at the number of patients that are being enrolled in the studies. 180, 200,000 men. And these men are randomised into 2 different groups in multiple countries, having similar criteria for assessment over 11-year timeframes. So what's the 12-year data looking at the screening studies? And I apologise for getting into a little bit of detail here, but the data that you look for is how many patients do you need to screen to prevent 1 death? And how many patients do you need to treat with whatever treatment with intent to cure to prevent 1 death? And those are the 12-year data based on those 200,000 patients enrolled, showing that you need to treat 33 men in a screening-based study to prevent 1 death. So it's quite a lot of treatment and quite a lot of assessment. And that's because prostate cancer is a very long natural history of disease before a lot of patients have trouble with it. So if we go down to the bottom line here, the 12-year data suggests a 29% reduction in mortality rate in the screening groups. It's a very expensive process for an improvement, but you would expect prostate cancer at 15 years, the data to be further separated because it's a long and slow progressive disease. So, in 2009, it has been shown that screening reduces mortality. No one centre in Europe made the difference. The number needed to treat and the number needed to diagnose have come down, and only a small number of people who have randomised over that time have died. Longer follow-up is still required for this, and at the moment, PSA screening is not recommended in any country worldwide. So the next thing we're trying to do here is give some standard information to GPs, and as John has alluded to, the goal is to provide that through the electronic referral pathways, which brings the information to the GPs and is required as part of their referral to us as hospital specialists. One of the things that's talked about is what are the problems associated with the diagnosis. So I thought I'd give you some feedback as to what we do in Christchurch, looking at our regular monthly audit of problems. And this starts back in 2009, where we look at our prostate biopsy infection rate from public and private by admission across the board, and we haven't seen, despite a 55% increase in the number of biopsies, a greater risk of infection. We're told nowadays there are lots of bad bugs out there, we're all getting more infections, we're dying of bad infections. We've got very clear data that doesn't suggest that. We use a very simple regime of preventing infections. So in reality, having looked at what we've done, we're trying to make sure we don't miss a problem. So we're looking very closely at what are the consequences. The infection rate on a biopsy hasn't consistently changed. What's happening in diagnosis? There's quite a lot going on now talking about MRI scanning. X-ray scanning looks for abnormalities in tissue, and MRI is a more detailed pelvic X-ray, and the prostate is poorly visualised because it's trapped between the bone, between a lot of soft tissue, and cancer is not that much different in density to the other tissue nearby. So it doesn't show up well on X-ray. But it appears by using some of the new MRI scans associated with PSA, you can get a more accurate diagnosis, you can get a more focused biopsy, and on the basis of that, there's been a recent study put out by one of our New Zealand trainees currently working in Brisbane in one of the main European journals, which have looked at comparing cost and accuracy of an MRI scanner, which most DHBs have and have access to, compared to our traditional way of doing biopsies. And what that has shown is, and what we want to do in prostate cancer, is diagnose more of the problematic cancers, not diagnose some of the low-risk, non-aggressive, slow-growing cancers. You want to do that without more cost or complications, so you can lower the overall cost of the disease to the community. And it ticked all of those boxes. This was only published 2 months ago and is the only one study that's shown it. So one of the difficulties in medicine, you've got to have things repeated in a number of places so that it is shown to be true in a number of units. But an MRI scan with a focused biopsy can increase the diagnosis of the high-risk troublesome cancers, decrease the diagnosis of the low-risk, non-aggressive surveillance cancers, which cause as much anxiety for people and a lot when they're being followed, because it doesn't make sense that you have cancer and it's not being treated. It reduces the number of biopsies and the potential side effects, and it does reduce overall cost of care, which is not common in medicine nowadays. So let's look at treatment next. We said treatment has improved. Surgery is undertaken between 40 and 60% of the times in a population. Radiotherapy between 20 and 40%. And active surveillance is around 30%. So if you're looking at access to care, roughly those should be the figures in a community of what patients have in the way of treatment delivery. What's happened with those? Well, as I've mentioned, since my time in training, the average hospital stay has reduced from 8 to 2 days. The continence has gone from 50 to between 80 and 90%. The transfusion rate has gone from 90% to 3%. And there has been an improved likelihood of cure. Robotic surgery now exists in 2, previously 3 centres in New Zealand. Robotic surgery improves your recovery, doesn't improve your cancer control, and makes a small difference to continence and erection function, but it is an advance because of an improvement in visual aids at the time of surgery. There's magnification. Radiation treatment offers increased options, lower complication rates, and improved care. and active surveillance, because people are being looked at and not actively treated, has a lower complication rate. A robotic prostatectomy sounds slightly science fiction, and in fact they have done robotic prostatectomies where the patient is in one continent and the surgeon is in another. The surgeon sits at a separate console, separate completely from the patient, and this is all keyhole type surgery with manual controlled laparoscopic equipment which is capable of being remotely operated by the surgeon. It gives you better 3D magnification in a small space, and it gives smaller openings, which means you recover quicker from surgery. Let's lastly look at patient outcomes. What are our goals? Our goals are treating the right patients, curing the cancer, and leaving the patient with the best quality of life possible afterwards. One of the things we know is that surgeon feedback on patient outcomes is critical to improvement in the surgeon performance of their procedure. And we're moving along with the Ministry of Health to look at 3 components, as John's talked about: access to care, timeliness of care, and quality of outcome care. And the aim is to provide much better data on the surgeon's performance and patient outcome from a procedural perspective, using real-time patient data which can be collected more electronically and presented back to us as surgeons in a format we can understand, so that therefore we'll improve our overall likelihood of a good patient outcome. The goal of that is the data should be accurate. It should be confidential to the surgeon, and that's a really controversial area, is should that stuff be out in the public domain, or should that be something that we look at and try and make sure is important to improve the performance of us as doctors. And lastly, we should set a benchmark of what's acceptable results. Is it 90% continence at 1 year? Is it 80%? And once we do that, we can work out where people sit and where do we need to look at improvement of quality of care. We're doing that in Christchurch at the moment, so I thought we'd look at just what do we actually show ourselves at the Times as part of our audit review. We have an 88% response rate at 1 year from our patients who go through surgical treatment, and we're looking at outcomes of surgeries. So that's a pretty high success rate at getting feedback from patients coming through. This gives you an idea of some of the graphs that we produce, both for individuals and collectively, and to talk you through it, it's what's called a health-related quality of life, not a particularly good term, but it's a well-shown measure that says how well are people doing. And what we can see here is the top line, the purple line, is bowel function, not likely to be changed with surgery. The second is your urinary symptoms, and the third is erectile function following surgery in all patients coming forward. And we are able to drill this down to individual surgeons, and we're able to try and provide data that we find useful to know how well are we doing. So you can see from our real-time data that was presented in our audit meeting 2 months ago, this is the sort of stuff we're looking at to try and improve what we do in the way of surgical care. We want to try and reflect this to something that is a national program. The last little bit is more interesting from a surgeon performance point of view, and I apologise for the difficulty of seeing these graphs, but this comes out of North America, where what they'll do is put individual surgeons' performance and outcomes of patients on a scatter plot, put a middle line, and as a surgeon you'll find out where you sit in relation to your colleagues on the basis of those 3 things: cancer control, continence, and erection function. And on the basis of that, you can say, where do I sit? And the goal for us is to try and put what is a benchmark in and say, this is what we're looking at trying to do to improve the outcomes of treatment for men with prostate cancer. We will use what's called a database, and that's a collection of measures that's standardised. And this is a group which is out of North America called the International Consortium of Health Outcome Measures. They provide standard outcome measures for diseases. Back pain, heart disease, localised prostate cancer is one of them. It's an international collaboration. We'll get benchmarking internationally. In Canterbury now, all of our public and private patients are entered onto a database that will be compared to that. We aim to have this as a national plan. We hope it will be involved and supported by the Ministry of Health and all public hospitals. And we're, I suppose, looking towards the Prostate Cancer Foundation for support with an overall goal as a similar model of improving patient care. So this project is a national patient database. The goal of this is to have accurate results, to be confidential, and for review the outcome to improve overall patient care. But it does require, as we're finding out, quite a bit of IT support, some funding, some standardised reporting, and a standardised confidential review process. So in summary, not all men are the same. And on the basis of that, our goal is to be very patient-focused with our care, to improve the length and quality of life of men and their family or whānau with prostate cancer. Thank you very much.
Thank you very much, Stephen. Now, Stephen's also happy to take questions. It's your chance to speak to a urologist, to get all the information you've ever wanted. Holly?
What you're saying is that...
Ian, can we just wait and get the mic? Thanks.
Thank you. What you're saying is that over a period of time you will have surgeons who will go on blacklist and will no longer be doing surgery because they're not up to a similar mark. If that's the case, how long will that take? And because it concerns me that there are good and bad, and you can have a mark system or whatever. It sounds like we need quality control, and those that what you're working with at the moment is that we want to make damn certain that the ones that are at one end are no longer doing it.
I think that raises a really important point, is that, as we all know, not every person has the same ability, but I'd have to say we are very lucky in New Zealand that the quality of healthcare is at a very high standard. We have the ability, as part of our jobs, to be able to see what systems are like overseas. And I would like to reinforce that belief. As we've heard before, we actually have a very good system. 3 aspects of measuring performance are useful. And it also is important because these are all to improve outcomes. We are starting off from a good level. It's not to provide a blacklist, it's to provide an improvement of everyone's quality of care by measuring how people are, showing to them how they're doing. We know 3 things about outcome measures. If you measure them just by process, you'll get better performance. Doesn't matter what you do, just by doing a measurement, it will help it. The second thing is, if you can make that outcome measurement useful and easily understandable, people will do more to improve their performance relative to where they're at. And the last thing is, it will give us an ability as a group to recognise if there is an issue, and therefore we have the ability to improve that. But at the moment, we have none of those. And I think focusing on one end of the spectrum possibly is the wrong way to look at it. But I can totally understand where you're coming from. We're wanting to improve the level of the lot.
Thank you.
Holly?
Hi, can you give me or give us any statistical results on the percentage of prostatectomies that are carried out where the prostate cancer has already moved outside the prostate capsule? I think the Americans use the term gold standard for when you successfully get the cancer before it's moved. But do you have any Christchurch statistics or New Zealand-wide statistics on that, please?
Sure. I don't have national statistics to hand, but I certainly have Christchurch statistics. When we look at prostate cancer treatment surgically, the goal is to cure the cancer and therefore remove it fully. It's important to also realise that some patients have a much higher chance of having disease outside of the prostate and have a higher risk condition, but because of their age, being maybe younger and having slightly more aggressive disease, you might look at a more aggressive treatment in that group because you've got more to gain. So it's not quite as simple as a single number, because as soon as you look at the different patients, you've got to look at it individually and say, what's your risk, what's your likelihood of benefit, is it worth taking that treatment punt? In those patients who we consider having localised disease, 84% have localised disease at the time of their pathology removal. They are the medium and lower risk group. The higher risk group, I don't have those figures off to hand. If we look at the international data that comes out of the Memorial Sloan Kettering Cancer Institute, where they have 14 surgeons who are dedicated to prostate cancer treatment, it is the same rate as they have.
Okay, thank you.
Yeah, hi there. I was just wondering if you have any visibility over the level of over-treatment, and do you measure that?
One of the concerns and criticisms of PSA testing, prostate cancer assessment, is there is a level of patient being treated, be it either with surgery or radiotherapy, who has a low risk disease who may not necessarily progress. And I suppose that's just some background to what over-treatment may be called. This is an evolving situation where surveillance or following cancer is now shown to be safe, and currently in Christchurch in the last 12 months, 28% of patients diagnosed with prostate cancer underwent active surveillance. In Melbourne, for the last 12 months, it was 19%, and that was presented at our last urological meeting, which was part of the American Urology Society meeting in where was it? Orlando, just 3 months ago. So we are trying hard to be in that level, which should be having what's called a surveillance group. And one of the things from within a population, if you look at the number of men undergoing different types of treatment, surveillance, surgery or radiotherapy, you should get a pretty good idea if they're being offered correctly treatment options fairly, because of the percentage within that population that should be having each treatment. But those were our numbers.
All right, we're all done. That's good, Stephen. Thank you very much for being part of this here today, and we also appreciate, as I said at the beginning, the partnership with the Urological Society. And as Stephen mentioned, with the ICOM database that they've started to pilot in Christchurch, we're looking to be part of supporting that because, as Ian pointed out, we're vitally interested in who's doing a good job, and if you can, as you say, lift the standard of everybody, that's to everybody's benefit. Just stay there. I've got a little gift for you to take.
Just passing on one of the things, I did, as part of this, have a look at the PCF NZ website, and it bothered me a little bit that the second article there suggested that if I was a road cyclist biking for more than, I don't know if it's 9 or 5 hours a week, both of which I actually go over, that I'd have a 5 times greater risk of having prostate cancer that was serious. So I'll have to look myself at a little bit of the research work epidemiologically out of the UK. So I've learnt something.